Hello everyone and welcome to Blood and Hematology YouTube channel and case presentation and discussion video series. In this video the patient case number 2 will be discussed. A 69-year-old woman with relative lymphocytosis and few smudge cells in the peripheral blood smear was presented. Based on the presence of a homogeneous population of lymphocytes, 10% smudge cells, and lymphocytes with clumped chromatin and suspect to neoplastic, a non-reactive and clonal etiology was suggested. The lymphocyte subpopulations and clonality were evaluated through flow cytometry. A pronounced B-cell increase and clonal CD5 positive B-cell population with kappa light chain restriction were observed. Lymphocytosis, defined by an increase in absolute lymphocyte count to more than 5,000 lymphocytes per microliter in adult patients, is a common hematologic abnormality. An absolute lymphocyte count of 5,000 per microliter or higher has been suggested as the threshold in need of further investigation to identify infectious, autoimmune, or neoplastic etiology. A complete history and physical examination should represent the first step of such an evaluation, aimed at identifying causes of reactive or polyclonal lymphocytosis. The most common cause of reactive lymphocytosis is viral infections, autoimmune conditions, smoking, hypersensitivity reactions, acute stress, and splenectomy can also induce polyclonal lymphocytosis. If the clinical and laboratory evaluation point toward a neoplastic origin, clonality should be evaluated through flow cytometry. A variety of clonal B-cell disorders can be identified based on surface protein markers with such analysis. The detection of clonal B cells with a non-CLL phenotype or T-cell monoclonal lymphocytosis should warrant further testing, including computed tomography imaging, bone marrow biopsy, and molecular and genetic studies according to the suspected lymphoproliferative disorder. Smudge cells are ruptured or damaged fragile leukocytes during the slide preparation of peripheral blood, as in vitro artifacts. They may be presented as bare nuclei isolated from the broken cells, varying from well-preserved nuclei without cytoplasm, to smudged nuclear materials with the arrangement of strands in a coarse network and therefore named basket cells. It has been suggested that smudge cells in case of atypical lymphocytosis such as CLL or acute leukemic changes are constituted of apoptotic leukocytes dying in circulation. In patients with CLL, the percentage of smudge cells could be a prognostic indicator. The presented patient with relative lymphocytosis, increased B-cell count and clonal CD5 positive B-cell population with kappa light chain restriction, was diagnosed as monoclonal B-cell lymphocytosis. MBL is an asymptomatic hematological condition characterized by the presence of clonal B-cell population with a count of less than 5,000 per microliter in healthy individuals. Individuals with MBL are at an increased risk of developing hematologic and non-hematologic cancers, serious infections, and progression to CLL requiring therapy. MBL can be categorized as either low count or high count based on whether the B-cell population in the peripheral blood is above or below 500 per microliter. Low-count MBL can be detected in about 5% of adults over the age of 40 years when assessed using standard sensitivity flow cytometry assays. Low-count MBL rarely progresses to CLL. High-count MBL progresses to CLL requiring therapy at a rate of 1 to 2% per year. The most common subtype of MBL is defined as CLL-like. The immunophenotype of the B-cell clones in approximately 75% of all MBL cases is similar to that observed in CLL, which is positive for CD5, CD19, and CD23, with low levels of CD20 and surface immunoglobulin, that in most cases is IgM with or without IgD. Other immunophenotypic characteristics include the absence of FMC7 and the weak or no expression of CD79b and CD22. Atypical MBL is another immunophenotype occasionally observed in MBL which is characterized by strong expressions of CD20 and surface immunoglobulin along with absence of CD23. The last, most infrequent, MBL subtype is CD5-negative MBL, in which the complete immunophenotypic characterization is CD5-negative, CD19-positive, CD20-positive, with moderate to high surface immunoglobulin expression. The ratio of kappa to lambda surface immunoglobulin being strongly skewed, either more than 3:1 or less than 1:3. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.